So we're back here and we're going to talk about some of the cardiac infectious diseases. So before we really talk about the infectious diseases of the heart, we really should keep in mind the anatomy of the heart. And the heart is infected by its different layers. So when we think of cardiac infections, we should think of the layers of the heart. So the innermost layer is the endocardium, and that's consistent with the valves. So anything that infects the endocardium can infect the valves too. The myocardium is the middle layer, that's the muscular layer, and that's responsible for contractility. So anything that infects the myocardium is going to affect the contractility of the heart. And then the epicardium is the outer surface of the myocardium, and the pericardium is the outermost surface of the heart, which holds a potential space with the epicardium. So between the pericardium and epicardium, there is a space there which generally holds no volume, but it can hold volume if anything secretes into it. And that's going to be important when we talk about pericarditis. So we're going to talk about endocarditis, which is broken into acute and subacute, and then pericarditis and myocarditis. And I really should just preface this that the endocarditis, pericarditis, and myocarditis are all general terms for an inflammation of those respective layers. We're going to talk about infectious endocarditis, infectious pericarditis, and infectious myocarditis. But there are non-infectious causes of all of these inflammations as well. So keep that in mind. So endocarditis is inflammation of the inner layer of the heart. And the primary consequence of this is that it affects the valves. And because it affects the valves, it's going to affect the circulation through the cardiopulmonary circuit. This tends to be a hematogenous spread. So you get endocarditis because you have sepsis, rather than the other way around. The predisposing factors are things to keep in mind, because when you get a patient's history, these factors are going to exist more often than not. I would say the vast majority of time, the patient's going to have one of these factors. And the number one is heart surgery. Another one is prosthetic valves. Another one is high-flow valvular disease, which I'll explain. IV drug use is a very high risk of endocarditis, and then dental surgery, and we'll explain why that is as well. So what is a high-flow valve disease? A high-flow valve disease is any valve disease where there is a high velocity of blood flow through it. So any stenotic lesion, mitral valve prolapse with murmur, and any congenital heart disease besides the septal defects. So if you think of the septal defects, those are large holes between the relatively large holes between the atria or between the ventricles. And because the holes are so large, you don't have a very high velocity flow, and so you're not at risk for endocarditis there. The congenital heart disease that is highly associated with endocarditis is patent ductus arteriosus. I would say another predisposing factor that I didn't include on here would be Marfan syndrome. Okay, so the three classes of patients should be considered, and that would be those with native valves, and this is primarily going to be your congenital heart disease patients, patients with prosthetic valves, and then IV drug users, because these patients are going to attract different kinds of bacteria based on their valves and their practices. So the offending agent, patients with native valves, the offending agent is most commonly strep viridans. Patients with prosthetic valves, the offending agent is primarily Staph epidermidis. There are multiple different causes. These are just the number one causes, but there are many different possible causes. Patients with IV drug use, the primary cause is Staph aureus, and that tends to be the majority because Staph aureus is part of the skin flora. Rarely, Enterococci can be implicated, and then gram-negatives can be implicated as well, and those are the Hosek organisms. That's like Klebsiella and Haemophilus. Don't worry about what those bacteria are. Just know that those are they're slightly more common in children, and know that gram-negative bacteria can be implicated in endocarditis. So what comes out of this is that antibiotic treatment for endocarditis has to include coverage for Staphylococcus, Streptococcus, and gram-negatives. And when I say Staphylococcus, I mean methicillin-susceptible Staph aureus and methicillin-resistant Staph aureus. So we're really looking at 4 different classes of bacteria that we have to tailor our treatment towards when we're looking at empiric therapy. Okay, so endocarditis, as I mentioned, is infection of the inner layer of the heart, the primary consequence of which is seeding and destruction of the valves, and it's spread hematogenously. In general, you should suspect endocarditis when you have a patient who has a fever and a new murmur. So endocarditis is broken down into subacute infective endocarditis and acute infective endocarditis. And they're very different based on the patient population and based on the symptoms, more so the chronicity of the symptoms. However, your physical exam findings and your diagnostic criteria are going to be the same. So subacute infective endocarditis comes on slower. And so these are going to be patients that have prosthetic valves or have native valves and happen to have sepsis. So this is an endocarditis that comes on slower. The patients will tend to have a flu-like syndrome, so they may have body aches and pains and fever. Usually that fever will be low grade. They may have some unintended weight loss, some nausea, vomiting, really non-specific signs, very slow onset, and of course they will also have a new onset murmur. Patients with acute infective endocarditis, on the other hand, those tend to be the IV drug users, and these patients will usually come in for other reasons because they have hemodynamic instability, they have a fulminant septicemia, they have chills, thrombosis, they may have signs of congestive heart failure, so dyspnea and chest fullness and trouble breathing, edema. So you have to break down, when you're thinking endocarditis, you have to break down whether you believe it's subacute or acute. And that's primarily going to be on the patient's history, whether they're an IV drug user or not, whether they have prosthetic valves or not, and the onset of their symptoms. One is slow, the other is quite fulminant and rapid. Now, both classes of these patients will show similar physical exam findings as far as the pathogenesis goes, and as far as skin manifestations and immunologic manifestations. So petechiae are quite common in patients who have endocarditis, and that's just a manifestation of the overall sepsis rather than the actual heart inflammation itself. So petechiae is something to look for in patients with suspected endocarditis, and petechiae are just small, non-blanching red lesions on the skin, which is due to a disruption of the microvasculature. Splinter hemorrhages are small, thin, linear red lines on the nail bed, and those are another thing that are very common in patients with endocarditis. It occurs in approximately 1 in 5 patients. It's also quite specific. Osler's nodes are an immunologic manifestation, and those are painful nodes, nodules on the beds of the toes or fingers. Janeway lesions are red macula. So they're not petechiae, they're macula. Petechiae are small red lesions. I don't know what exactly the cutoff is. I think it's like 2 millimeters or so. Janeway lesions are macula, so they're larger red lesions. So if you see small pinpoint lesions, those are more petechiae, whereas the macula, the larger red patches, those are Janeway lesions. Roth spots you would see when you look into the eyes with an ophthalmoscope, and what those are pale spots on the retina which are surrounded by an erythematous margin. Glomerulonephritis is a manifestation as well, and that's primarily, again, due to sepsis, and a positive rheumatoid factor is another thing that you can see on laboratory. The diagnostic criteria are what we know as Duke's criteria. So there is a criteria for diagnosing endocarditis formally, and the rule is you either have to have 2 major criteria, which there only exist 2, or 1 major criteria plus 3 of the minor criteria. So the major criteria is a positive blood culture. Now, how often are you going to have this in acute endocarditis and acute infective endocarditis? Pretty much never, because when you're diagnosing endocarditis in patients who have acute infective endocarditis, you're going to be making this diagnosis as soon as possible. And the blood culture takes a few days to come back. So usually you're going to have to use 1 major and 3 minor criteria. An abnormal echocardiogram is another major criteria, and that's just any echocardiogram that shows any abnormalities for any reason. Now, the minor criteria are going to be fever. That's pretty easy to have. A predisposing heart condition, so basically any patient that's got a heart condition, primarily a congenital heart lesion, or any patient that is using IV drugs. Vascular phenomena such as petechiae, thrombosis, Janeway lesions, and splinter hemorrhages. Immunologic phenomena such as Osler's nodes, Roth spots in the retina, glomerulonephritis, positive rheumatoid factor, or other microbiological evidence. So 2 major criteria or 1 major plus 3 minor criteria, and that's diagnostic of endocarditis. So when a patient is suspected of having endocarditis, first of all, keep in mind that you're always treating the patient as the patient. So the emergency management comes first, your A, B's, and C's. And patients with fulminant septicemia should be treated as any patient with fulminant septicemia should, and that's with fluid and pressors. And that's because these patients because they're septic, they're having a low blood pressure, and so you need to stabilize their blood pressure. So bolus, normal saline, and epi, norepi, or dopamine. Patients with severe congestive heart failure symptoms should be treated accordingly, and that would be diuretics and beta blockers. Cultures should be taken before initiating antibiotics, and that's because culture is the most accurate diagnostic test in endocarditis. And in most infectious diseases, culture is the most accurate test. However, we obtain that culture, be it through blood culture, be it through sputum culture, be it through an aspiration of an abscess or whatnot. Culture here of the blood is the most accurate diagnostic test. Now, the best first diagnostic step is an echocardiogram. So if USMLE asks you if you have a stable patient, which of the following is the best first step in diagnosis of this patient, it's echocardiogram. And that goes back to Duke's criteria. We need to get an echocardiogram to establish that major criterion. Now, as far as labs, and this is important for step 3 people, you're going to want to make sure that you have a CBC, a CMP, and a urinalysis, of course also a culture, and before you start antibiotics, and you're going to want to check for rheumatoid factor. Again, going back to Duke's criteria, these are all important things that are going to help you establish diagnosis. Now, any patient that's in critical condition, if you're managing them emergently and you're suspecting endocarditis, or if they continue to show septic signs and they have a echocardiogram that comes back abnormal and you're suspecting endocarditis, you should start empiric antibiotic therapy. And of course, you should start empiric antibiotic therapy in all patients that are diagnosed with Duke's criteria. So how do we manage these patients with antibiotics empirically? Empiric means different things in different diseases. Empiric in pneumonia is something different from empiric in endocarditis, which is different from empiric in tuberculosis, which is different from empiric in a UTI. So empiric antibiotic management in endocarditis means that we need to cover the major causes. And the major causes, as we mentioned, is Staphylococcus, both MRSA and non-MRSA, Streptococcus, and gram-negative bacteria, particularly those Hasek organisms. As far as covering Staphylococcus, the and let me preface this with all of the management antibiotically should be intravenous. So as far as managing the Staphylococcus, we should use oxacillin or nafcillin. We can also use the anti-MRSA agent vancomycin or linezolid. And we're going to see vancomycin is almost always the best drug of these four to use. As far as managing the Streptococcus, we can use penicillin or amoxicillin. If the patient is penicillin allergic, as usual, we can use a macrolide. For covering the gram-negative bacteria, we should use an aminoglycoside, and generally we use gentamicin. Now, vancomycin is a good drug to use, and we almost always use it in endocarditis because it covers both MRSA, non-MRSA staph, and it covers strep. So we can kill two birds, or really three birds, with one stone. And so vancomycin covers the MRSA, non-MRSA, and Streptococcus. Gram-negative, we tend to use gentamicin, but we can use any aminoglycoside. And there's probably other antibiotics that can be used. But for the USMLE, the standard of care tends to be vancomycin and gentamicin. When you get a question on the USMLE that's asking you which of the following is the best antibiotic therapy for this patient who has endocarditis, the answer is going to be vancomycin and gentamicin. If you have to, on step 3, if you have to choose drugs, choose vancomycin and gentamicin. So patients with endocarditis should be managed inpatiently for at least 3 to 4 days with cultures drawn after those 3 to 4 days to ensure hemosterility. You should not discharge patients who have bacteria in their bloodstream. On discharging the patient, you should advise them of possible complications, which include but are not limited to development of congestive heart failure, relapse, and other end organ dysfunction, particularly renal dysfunction. Good oral hygiene is important because it's always possible for anybody to, and most people have bacteria in their blood. Doesn't mean they're septic, but they have bacteria in their blood that is resultant from just flossing or brushing your teeth and so forth. Patients who have had endocarditis are at further risk of getting endocarditis again just for the fact that they have had a history of endocarditis. And so these patients definitely want to make sure that they are maintaining good oral hygiene. So Listerine, brushing teeth after every meal, and so forth. Patients who have history of IV drug use or the IV drug use precipitated the endocarditis should be referred to drug treatment centers. And there should be frequent follow-up, at least in the first year, for these patients. And important to remember that these patients that have had endocarditis will be required to take endocarditis prophylaxis before all appropriate procedures, just due to their history of having had endocarditis. So what is endocarditis prophylaxis? So endocarditis prophylaxis is, as its name insists, it's therapy to prevent the development of endocarditis. And who gets endocarditis prophylaxis? This is a common question on the USMLE. The USMLE wants you to know who needs endocarditis prophylaxis and who doesn't need endocarditis prophylaxis. The rule is that all patients who have prosthetic heart parts need to get endocarditis prophylaxis. All patients, as I mentioned earlier, with a history of endocarditis, just as a fact that they've had endocarditis before, need to get endocarditis prophylaxis. All patients with congenital heart disease that has not been surgically treated need to get endocarditis prophylaxis. And that's the exception being atrial septal defect and ventricular septal defect. And then all patients with mitral valve prolapse with the diastolic murmur need to have endocarditis prophylaxis. If you have mitral valve prolapse and you do not have a murmur, you do not need endocarditis prophylaxis. It's only if you have that diastolic murmur, that rumbling sound that comes with mitral valve prolapse and the ones who have murmur. Those patients, the ones with murmur with mitral valve prolapse, they need to have prophylaxis. So when do these patients get prophylaxis if they need it? They get it before dental procedures and before tonsillectomy or adenoidectomy. Always, always, always in those cases. Now, there's some guidelines that say that they need it during the drainage of an abscess or during the incision of respiratory mucosa. There's controversy about that. So I would remember that sometimes those patients, some people would recommend that those patients have it, but the USMLE, it would be unusual for them to test you on that because it's controversial. So just remember, don't commit to memory all the procedures that don't need prophylaxis because there's so many. Just remember that they need it before dental procedures always, tonsillectomy and adenoidectomy always, and there's some controversy behind drainage of abscess and incision of respiratory mucosa. And as far as how we administer the prophylaxis, it's oral. So oral amoxicillin is given if the patient is allergic or sensitive to the penicillin class of drugs. Then you can use a macrolide as usual or a third-generation cephalosporin. And you're administering this oral medication 30 to 60 minutes before procedure. And this is like in any kind of surgery. Before you cut the skin, you're giving generally they'll give like Keflex before surgery, half an hour to 60 minutes before procedure. So this is like in any surgical prophylaxis. So oral amoxicillin within an hour of the procedure. Okay, so we've spent a lot of time talking about endocarditis, and that's the most significant of the cardiac infections. Now let's spend some time talking about pericarditis and myocarditis. And we'll start with pericarditis. Pericarditis is an infection or inflammation of the pericardium, and the pericardium is that outer layer. So this can lead to fluid collection in the pericardial sac. So remember that the pericardium is the sac that covers the heart, and the pericardial sac, I suppose the pericardial sac might not be the best term to use, that's what they say, but what the pericardial sac is, it's not the pericardium itself, it's the space, the potential space between the pericardium and the epicardium. So a potential space is a space that doesn't hold any volume, but it could hold volume if something leaks into it. So the pericardial sac is the space between the pericardium, which is an actual histologic layer, and the epicardium, which is just the outer part of the outer margin of the myocardium. And because this can hold fluid, it can result in tamponade. Now, the cause of infectious pericarditis is usually viral. That doesn't mean that the most common cause of pericarditis is viral. It means that the most common cause of infectious pericarditis is viral. You can also have TB as a cause of pericarditis as well. There's also non-viral causes of pericarditis, and I would actually say that these are more common. Uremia is a very common cause of pericarditis. Trauma can cause pericarditis just in the fact that you have trauma to the heart, and that causes a direct inflammation. Lupus can cause pericarditis, and then the post-MI period you can actually develop a pericarditis because you're exposing internal antigens to the bloodstream. So when and this is more of a cardiology topic, but when the heart cells necrose, these foreign antigens in the inner part of the heart cell that aren't generally exposed become exposed, and then you get an immune reaction. And so you can develop pericarditis in the post-MI period as well. That's called Dressler syndrome. And I address that in the pericarditis section of the cardiology slides. And then, of course, there's idiopathic pericarditis. Now, pericarditis is somewhat easy to diagnose symptomatically. It's positional and pleuritic chest pain, and there's not many causes of positional pleuritic chest pain other than pericarditis or pleurisy. There's some other ones that are non-heart related, like a pneumothorax or a PE, but pericarditis is always positional and pleuritic. And in pericarditis, it tends to be, well, it's always better when the patient is sitting up and leaning forward. So when you come in and see these patients in the ED, these patients will not be laying down. They're going to be sitting up in their bed. And some patients with pericarditis, just the fact that they have inflammation going on somewhere in the body, they could be febrile, but they don't have to be. And some patients, but certainly a minority, will have hemodynamic instability, and that's, of course, if they have an effusion in their pericardial sac and they actually have cardiac tamponade. On physical exam, there's very few signs present, if any. So fever could be present, but the classical signs that they teach you in second year of medical school is the pericardial friction rub, which is just as it sounds, a friction rub that's heard during the entire heart cycle. Muffled heart sounds, which is often muffled from the friction rub. And then pulsus paradoxus if there's actually tamponade present. And pulsus paradoxus just means that when the patient breathes in, that you get a drop in blood pressure of greater than 10 millimeters of mercury, and you also get some jugular venous distension. And that's because you are increasing the pressure in your thoracic cavity, and that's causing pressure on the left ventricle, which in addition to the effusion is causing such a high pressure in, well, the left and right ventricle is causing such a high pressure that you're getting jugular venous distension. Okay, so again, I also talk about pulsus paradoxus in greater detail in the cardiac sections. So we're just kind of glossing it over here. We're exposing more of the infectious topics of pericarditis here. So the first diagnostic step in any patient with general chest pain, and this goes for pericarditis-like chest pain, angina-type chest pain, even pleuritic chest pain, even chest pain you think might even be GERD. The best first step in any patient with chest pain, especially if they're older or have any risk factors for MI, is going to be EKG. And EKG will actually help you in the diagnosis of pericarditis. It might not help you with all of the causes of chest pain, but you have to get MI ruled out because there's such a liability with that, and there's such a strong possibility of that, and that's something that needs to be addressed right away. Other things can wait. So EKG is going to show diffuse T-wave elevation, and those ST elevations are very unique to pericarditis. So we're not talking ST wave or ST elevation in 2 or 3 leads. If you saw that, you'd be thinking STEMI. You're seeing ST elevation in all your leads. And This is unique, as I mentioned, to pericarditis. Another thing that you can see is electrical alternans, and all that is alternating QRS voltages in your leads. So you could have a tall QRS wave, and then a short QRS wave, and a tall QRS wave, and so forth. And that tends to mean that the patient has a large effusion or tamponade. And that can be due to effusions or tamponades of any cause, not just pericarditis. The patient should subsequently have an echocardiogram to assess for effusion, and then the therapy is going to be NSAIDs. So indomethacin, ibuprofen, or naproxen are most commonly used, but any NSAID will suffice. If the patient does not respond to NSAIDs alone, then you can add steroids. Patients, however, who have TB pericarditis should be started on NSAIDs and steroids together immediately. Surgical options include pericardiocentesis and the establishment of a pericardial window, and that's going to be appropriate for patients that have severe symptomatic effusions or tamponade. And this is an EKG in a patient that has pericarditis, and you can see here that they've got ST elevation in all of their leads. So if you saw ST elevation in a patient with chest pain and it was just 2-3 in AVF, you might think, okay, this patient's got an inferior wall STEMI. Or if you saw it in V3, V4, V5, and V6, you might think this patient's got a lateral wall STEMI. But in fact, you see it in all leads. So it makes you suspicious of not a STEMI, but pericarditis. And of course, the symptoms, the positional pleuritic chest pain, that's not consistent with STEMI. That's consistent with pericarditis. You don't see the electrical alternans here. If you were, it would be like a QRS wave that's tall, and then a QRS wave that's short, and so forth. So this patient, while they have pericarditis, clearly they don't have an effusion. Okay, so myocarditis. Myocarditis is infection and damage to the myocytes, possibly even leading to necrosis of the myocytes. And that may sound familiar because that is what happens when you have a heart attack. So myocarditis can actually mimic the effects of MI, mimic the sequelae of MI, and be very similar to an MI in everything other than the acuity of the symptoms. So the cause of myocarditis is, when it's infectious, is most often viral, and so the Coxsackie B viruses, echovirus, and HIV, but really any pathogen can cause myocarditis. Fungal pathogens, parasitic pathogens, and so forth. So there's bacteria that can cause myocarditis. Rickettsia can cause myocarditis, like in Rocky Mountain spotted fever. You can get Lyme's myocarditis. You can get parasites that cause myocarditis, like Chagas disease and toxoplasmosis. But like I said, the most common infectious cause of myocarditis is viral. There's also non-infectious causes of myocarditis, like chest radiation, certain drugs, and hypothyroidism. The symptoms are going to universally include myocardial dysfunction, and that's not really a symptom, that's a kind of a syndrome. And that's dyspnea, cough, chest fullness, fatigue, palpitations, edema. Kind of sounds like congestive heart failure, and that's really what it is, because when you think about it, when your myocytes die, you can't pump. When you can't pump, you get congestive heart failure. And so this is problematic. And you can see how it's similar to an MI in everything but the chest pain. Myocarditis can also lead to sudden death, and the reason of that is that because you're getting death to your myocytes, you can develop a sudden arrhythmia, VFib, VTAC. Really any arrhythmia can come out of myocarditis. So it's kind of this sort of diagnosis that is always on the radar. But what's most prominent in myocarditis when it becomes symptomatic is that you get congestive heart failure-like symptoms. Physical exam can be normal, but a lot of times you're going to show signs of congestive heart failure. So edema, rales, crackles. S3 murmur is common just for the fact that you have the myocardial dysfunction and the left-sided congestive heart failure. Remember that S3 murmur is the murmur that you get from excess blood left over in the left ventricle. And so when blood comes down through from the left atrium into the left ventricle, the blood splashes up against the blood in the left ventricle, and that causes an S3 murmur. The way we diagnose myocarditis, the best first diagnostic step is an EKG, and the reason we want to do an EKG is to check for any possible arrhythmias. We want to exclude any present disorders, and so really it's more to look for other things rather than the myocarditis. Myocarditis is more in practice a diagnosis of exclusion. So the best first diagnostic step is an EKG, but a lot of times it's going to be nonspecific. You could see any array of arrhythmias. Most notably, you can see heart blocks. And then we're also going to want to get cardiac enzymes. And this is going to be where more of the meat of your diagnosis is if you do indeed diagnose myocarditis, because you would often have elevated heart enzymes. And it would be very unusual to have an elevated CKMB and LDH and troponin in a patient that's not having MI-like chest pain. Why would you be having heart cells dying when you're not having anginal chest pain? Myocarditis would be a logical explanation. So cardiac enzymes is going to be critical towards your diagnosis of myocarditis. But positive cardiac enzymes itself, again, is not diagnostic of myocarditis. Really, there's no way that we can actually diagnose myocarditis definitively without getting a myocardial biopsy. That is the most accurate test for diagnosing myocarditis. However, it is not commonly performed. As I mentioned, the EKG features that we commonly see in myocarditis are any kind of arrhythmia, commonly a heart block. We could also see EKG features consistent with left heart failure, but again, that's not diagnostic of myocarditis because that can be from other causes of left ventricular hypertrophy. And so those we would see high amplitude, high QRS amplitude in leads 1, AVL, and 3 through 6. So anterior and lateral. Diffuse T-wave inversion is also associated with myocarditis, and saddle-shaped ST elevations. But again, none of these are diagnostic of myocarditis. They just add to your index of suspicion. As far as the treatment for myocarditis, we're going to treat this like congestive heart failure. We're just treating this symptomatically. That's all we can do for myocarditis. There's nothing, we can't fix the heart itself, and we can't necessarily eradicate the virus. So we treat myocarditis. The best way to treat it is symptomatically, and generally those symptoms tend to be congestive heart failure symptoms. So we treat it just like we would treat congestive heart failure. So that would be ACE inhibitors, beta blockers, diuretics, low sodium diet, and so forth. For how we treat congestive heart failure, I have a whole section on congestive heart failure back in the cardiac section. Important here that we remember not to administer steroids. So myocarditis, no steroids. Pericarditis, yes steroids. Just remember that as a rule of thumb. And that is the end.